My dear friends and my dear colleagues, it is indeed a great occasion today for me and Dr. Simanti to be with you this evening to discuss something which is absolutely contemporary and challenges. That the challenges of diabetes in India and how do we surmount it? How do we face it? Dear friends, needless to mention that your presence with us gives us inspiration and gives us the josh to do this program and so that we can have a lively discussion. Shimanti, would you like to leave to kindly greet our audience before we start the questions?
Good evening, sir, and good evening to all the doctors who are listening to our program today. Thank you, sir, for your kind introduction. And as you said, today we are discussing a very contemporary topic, the challenges that we face in our Indian diabetic patients. What might be the barriers and how we can overcome them. Today, I will discuss as what are the barriers in managing diabetes in Indian patients? What are the barriers that we face as a physician, the patients face, and ways to overcome these barriers? Can you please add my slides? So, the topic of discussion today is type 2 diabetes in India challenges and possible solutions. The challenges for diabetes in India include improved education to alert the population about the risk factors for diabetes, training of patients to manage their disease more effectively, development of more structured care delivery, and management of the cardiometabolic risk factors. It's essential to diagnose the disease early and start aggressive management because the load of diabetes in the Indian population is huge. Indians start diabetes at a relatively younger age compared to the Western counterparts. Also, they have higher insulin resistance and higher cardiometabolic risk factors. It's also mandatory to individual glycemic targets based on comorbid conditions. So, we have to identify the barriers to diabetes management because it's necessary to improve the quality of diabetes care, including the improvement of metabolic control and diabetes self management. So, there can be patient related barriers such as lack of awareness in our population, economic stress, changing behavior, and sustaining to the changes are difficult for many patients. Rural barriers such as high rates of illiteracy, poverty in our country, insurance doesn't cover the cost of the medications. Different socio-economic strata, multilingual population, cultural, religion, custom, and barriers relating to the medical profession, including medical training focused of mainly on acute care, but the chronic disease burden is also quite huge, and we need to have a multi-pronged approach for diabetes management so we can provide our Indian population the best of care. And so, what are the strategies? We a considerable part of our population is also having pre-diabetes, as seen in the ICMR INDIAB study, and the link between pre-diabetes and cardiovascular complications have been established, and physicians should be aware of the implications for their patients. So, we should be able to manage pre-diabetes and prevent the complication. The first step in managing pre-diabetes is to encourage lifestyle modification, and they have to have a proper structured diet and physical activity greater than 180 minutes of physical activity per week, and a calorie intake of around 1200 to 1800 kilocal per day. In addition to lifestyle management, we can also advise them anti-obesity agents as required, such as orlistat, lorcaserin, or phentermine. Healthcare provider can also consider pharmacological agents such as pioglitazone, metformin, or acarbose for management of prediabetes. And if medical management fails to achieve glycemic control, advanced measures such as bariatric surgery can be offered to them. So, what are the therapeutic strategies for management of type 2 diabetes? We have novel medication therapy for type 2 diabetes, which include the DPP4 inhibitors, of which we have sitagliptin, vildagliptin, saxa, aloe, and lena. The SGLT2 inhibitors, the dapagliflozin, empagliflozin, and canagliflozin, and the GLP-1 receptor analogs such as liraglutide, dulaglutide, and semaglutide. In our population, early initiation of combination therapy helps in achieving the glycemic goals earlier and delaying the deterioration of glycemic control and possible lesser complications over time. For example, metformin and the SGLT2 inhibitors provide a combination of early efficacy, reduced risk of hypoglycemia, weight loss, BP control, and thus prevents the patient from complications. We also need more and more patient education programs so that we can empower our patients to manage their blood sugar better. Both of them are key steps in assuring good glycemic control. However, the facility and adequate manpower for these are not available even in major cities. Priority must be given for creating awareness among the public and to patient education. Patient education programs are generally cheap and cost effective, and they can also prevent life threatening complications. Another important thing which has risen during the pandemic are the telemedicine strategies. Telemedicine can be a strategy for closer monitoring and intervention to achieve not only better metabolic control but also to help in the global care of individuals with concomitant chronic diseases. Over the last decade, several studies have addressed the feasibility and efficacy of telemedicine strategies in the management of diabetes patient, and they have proved to be beneficial. So in this multi-pronged approach of starting treatment early, treating the complications, patient counseling, more and more stress on lifestyle modification, we should be able to provide the best of diabetes care to our patients.
Fantastic. Now you see in your presentation you alluded to the education being one of the barriers. Now it has been said that the diabetes is benefited most, that diabetic who knows most. So how, little will you dilate little bit on how education and awareness is lacking in our Indian diabetics, and how we can bridge the gap.
Yes, sir. Studies have shown that awareness of diabetes and its complications is not up to the mark in our Indian diabetes patients. And India being the diabetes capital as well as coronary artery disease capital of the world, we need to inculcate it early diagnosis of diabetes, make our patients aware. But how we can do that? First, we can educate the patients through programs, through flyers, through social media regarding the diagnosis of diabetes.
And
Then,
programs as you're doing today, and programs such
yes,
as you are doing today.
yes, sir. Then, when we can educate the patients on one-to-one basis, like those who have been diagnosed with diabetes, how to manage their diabetes better regarding SMBG, regarding ABGM or CGM, how they can and manage their sugars better. The main thing which we lack in our communication to patients is the short time that we deal with them. We have to listen to them with empathy and also provide them structured solutions. And this we can do through one to one communication. We can also guide them how to manage their complications better, especially the cardiovascular complications, because in
I think at
India
this
we
point,
have.
Dr. Simanti, I like to
Hmm.
ask you what you consider the most important cardiometabolic risk factors that our doctors and patients must be aware about.
Sir, obesity is one of the main maladies of the Indian population. We have lower BMI, but central obesity and visceral obesity, special visceral adiposity. I had listened, sir, to one of your early lectures where even pancreatic fat is predisposing to the risk of diabetes, and
And
loss of 1 gram of
I must
uh,
tell you, if you can lose 1 gram
1 gram.
of the ectopic fat in pancreas, you reverse diabetes. You're absolutely correct.
So we have obesity, we have non-alcoholic fatty liver disease, all that and can be premonitory signs of cardiovascular disease. People need to be counseled that walk, exercise, control your diet, because
Absolutely.
as if you don't change from the westernized diet to maybe a more structured Indian balanced diet, then and you might not be able to reverse the cardiometabolic risk factors totally. And it has been shown by the various landmark studies that if you control the blood sugar by proper lifestyle modification, you can delay the microvascular as well as the
I mean,
macrovascular
all the trials have
complication.
shown that. I want to ask you one thing. You said very passionately. You spoke about the risk factors. Now there are risk factors, Dr. Shimanti. We have no control. We cannot choose our parents. Many of
Yes,
us cannot
sir.
choose our in-laws, so we cannot stay at one particular age. So we have
Hmm.
no control on that. But I appreciate your emphasis on the controlling the modifiable risk factors. As you rightly said, the risk factors like obesity, very important, hypertension, tobacco, and you beautifully said that. So that must be taken care of. I just want to ask you at one point in this about walking. How many minutes of walking do you recommend?
Sir, if the patient is relatively young, then 1 hour, at least 1 hour of moderate intensity physical activity. And if the patient is above 50 years, at least 30 minutes of brisk walking 5 days a week, with not 2 consecutive days without walking.
Absolutely. I think that is fabulous. What we need is regularity. And do you think, Shamanti, that we as Indian doctors are well trained for the acute care? But for the chronic care, we lack. And what we lack, Simanti, I would like to convey to my audience what you spoke in your talk just a while ago, that for a chronic care, we need four T's. We need a team, and rightly pointed out, we have to give time to the patient. Listening, it is called, it's called diabetes care by ear. You have to give your ear to the patient to listen to this. Number three, you must have tools. And you talked about structured approach, like a structured SMBG, whatever, structured monitoring, structured treatment algorithm. And finally, the doctors must be well trained, because the science of diabetology is advancing very fast. But I must tell you, Simanti, I'm delighted to tell you the amount of knowledge explosion, amount of webinars and the knowledge dissemination in diabetes surpasses any other specialty. I would like to one important question. Today, we're talking about early aggressive control. So, I would like you to explain to our audience why this slogan, early aggressive control, and why we say this early aggressive control can be best done with a combination therapy.
So, early aggressive control is required, especially in our Indian patients who have a huge amount of cardiometabolic risk factors. And as we have studied before, that if we can have a early aggressive control, we can delay the complications by a few more years due to the metabolic memory, the metabolic legacy. I often counsel my inpatients that if you agree to my insulin therapy and intensive glycemic control for at least a month and maintain that properly, you might delay your cardiac or renal complication by around 5 more years. So, oh,
Fantastic.
combination therapy, we have a plethora of combination therapy, and some of them have been path breaking in times of cardiometabolic risk reduction. So, combination therapy, especially targeting the cardiometabolic risk factors, is need of the hour in our Indian diabetic population who are also at high risk of coronary artery disease.
Beautifully said.
And
Shivanti, I would like to tell you that the combination therapy is purely Indian. There are many Indians discoveries in diabetes which you and me
mm,
are proud of, Semanti.
mm,
One is
mm.
metformin use.
Yes, sir.
1957 we started using, America
Mm,
used
mm,
1993. We said screenings were done at 35. The other globe was saying 45. Now they have come back to 35. Combination therapy started in our country, and it gives three C's. It is cost effective, the compliance increases, and convenience, as you rightly said. So, which are the combination therapy which will take care of the cardiovascular risk, Simanti? Which
So
are the combination
cardiovascular.
therapy which will address?
So
Yes,
according to me, the SGLT2 with metformin and SGLT2 with sitagliptin will take care of the cardiometabolic risk factors that are prevalent in our Indian diabetic patients. The SGLT2 metformin itself has good cardiometabolic benefit
absolutely.
among the gliptins,
It's a
sitagliptin.
vascular drug. It's a vascular drug.
uh, uh,
Absolutely.
and sitagliptin has shown CV safety, and we have the gliflozin also. So a combination of a SGLT2 and a sita will be one of our top choices. Also SGLT2 plus metformin, because they
Absolutely fabulous. Yes.
provide so many benefits together.
Yeah, I think if you combine the SGLT2 metformin, you
Mm,
address at least five of the eight aspects of venous octane. And I also like
mm,
the way you said that if
mm.
you can, if you can think of a triple combination. I'm not discussing it
Yes,
in
sir.
detail,
Mm,
but that's also fabulous. If you
yes,
combine
sir.
metformin with a gliptin and with
Mm,
gliflozin, that will possibly address six of the eight venous octane. And believe me, Semanti, the people abroad, like the Fronjo,
mm,
like Paris
mm, mm,
Dandona, they start their
mm,
patient on these three or four drugs together in the beginning. And they have told me the combination is almost near to zero. So great, great,
mm,
great insight given. The other thing I want to tell you, with this availability of the dapagliflozin and the DPP-4 sitagliptin going off patent, do you think these drugs have become more affordable? What would you like to speak about this drug in the Indian market today?
So, with the drugs going off patent, they have become much more affordable for the general Indian patients, and their costs have come down so much in our country, since insurance company doesn't cover mostly the therapy of chronic diseases. Reduction in the price has been a boon for the uh, general Indian diabetic patient, because they are getting cardio protection at affordable cost, and that's a great step that we have come forward in our Indian diabetic patient population. So, according to me, I
I
think
think,
so. It's a
yeah, yeah,
great
it
blessing.
is great. What you said, I will describe it as I have discussed with you
Hmm,
sometime also, Simanti.
hmm,
It has become affordable, and you rightly said we no more glucocentric, so it is
hmm,
appropriate to take care of the severe risk, the severe risk, all obesity, da
hmm,
da 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 da,
hmm,
and it is available across pan India and easily accessible.
hmm,
Every drug shop has this.
hmm.
And I would like to
Yes.
ask you one combination. Still in India, one of the highest selling combination is the metformin and sulfonylurea. And there's a combination is also quite good, and it is widely available. And in the government sector, we have provided this drug to PSC and CHC. Of course, as you rightly said, metformin SGLT2 and the metformin DPP4 or metformin DPP4 SGLT2 has become a fabulous combination. But I also feel that metformin and sulfonylurea have still a role to play as given in the IDF WHO guideline and also our own RSDI ESI guidelines. What's your thoughts on that?
So sulfonylurea metformin is a very good combination, but in our country, one of the problem with our patients is follow up. Now, sulfonylurea metformin might increase the propensity to hypoglycemia, especially in elderly above 70, in
Yeah,
persons with CKD. If these patients are not coming to me, like in the pandemic, our patients didn't follow up for 1 to 2 years. So whatever complications they are landing with this combination, we might have missed. But the present combinations such as SGLT2 plus metformin might
yeah,
have some renal side effect plus minus, but the gliptin plus SGLT2 who at least doesn't have that much risk of hypoglycemia compared to the sulfonylurea
Rightly told.
metformin.
I think that's a very important issue you highlighted. Sulfonylureas have two problems. One is the weight gain, and the other is the
Yeah.
hypoglycemia. Very
Mm,
beautifully you said about it. But the bottom line, that if you monitor the patients, as you rightly said, monitoring and follow up is proper, and
sul-
you are checking the patient, advising the patients, then they have found that the hypoglycemia is not that big an issue.
That's
As you
true.
learned that in the Carolina trial, the
Yes,
hypoglycemia
sir.
was there, but much less. And both
Yes.
in Carolina, they have also established, Dr. Shimanti, that this combination of metformin and sulfonylurea, which is available in the government hospitals in a large, we'll be changing it over now very in a great volume. We have coined a term. Would like to see that term. I would like to say to our audience, Shimanti will like it. We call it, this combination is cardio safe and glucose smart. I repeat again, we have called it, I work for the government and I also in the private
Yes, sir.
sector. So we call it, this combination, Simanti, is cardio safe and glucose smart. I think you like this slogan because we want,
Yes, sir.
people, that's a very important issue. I'll come back to a question which is very close to your heart and my heart. That's about the pre-diabetes. Now, what do you think? Are we doing enough for the pre-diabetes? And what is pre-diabetes? And how do we approach a case of pre-diabetes?
So we say
Because why I'm
pre-diabetes.
asking this, Sumanti, that I co-chair the I7 INDAP study.
Yes,
The
sir.
diabetic prevalence was 10.7%, but pre-diabetes 14%. The numbers are very
Yes.
high. And believe me,
Yes.
Simanti, they are all waiting at the corridor to become diabetic. So how do you take care of this? Your thoughts on that? You can take 1 minute full to tell us about how do you manage pre-diabetes in our country? What is pre-diabetes? How do you manage?
Uh, So pre-diabetes, we say if the fasting blood sugar is between 100 to 125, if the postprandial, that is 2 hour after 75 gram glucose, if it's between 140 to 199, and if the HbA1c is between in 5.7 to 6.4, we call the patients as pre-diabetes. Now,
Absolutely
as
correct.
we have studied in the guidelines, those who are having a HbA1c in between 5.7 to 6 have a 10 to 25% chance of transforming into diabetes
Absolutely.
is over the
And
next
also,
5
I
years.
like
And
to ask, Simanti,
uh,
we Indians
uh,
convert faster. Am I
yes,
correct?
sir.
We
Yes,
convert faster.
sir.
Please continue.
Uh, and those above 6 have a 25 to 50% chance of transforming into diabetes over the next 5 years. So we need to treat this population with care. We first and foremost, I had heard in one of your lectures initially that fast food kills fast. So
Absolutely.
we have to counsel the patients that they need to modify their diet, what they need to do a proper diet according to their body weight, which is not rich in refined carbohydrates, but which is containing more of whole grains, a balanced amount of protein, 1 gram per kg body weight around, a combination of polyunsaturated, monounsaturated fatty acid, and at least 14 grams of fiber per day. A traditional Indian balanced diet usually contained all these proportions. But like urbanization, westernization, and our diet has shifted to mall cultures with more of fast food and more of soft drinks, which has increased the risk of diabetes. Secondly, exercise. We need to emphasize is that diabetes comes in those family where nobody runs in the family, so they need to
Absolutely.
walk physical
Beautifully said. The
activity.
slogan. Diabetes runs in those families where nobody in the family runs.
Yes.
Absolutely.
So they need to emphasize that if you're having pre-diabetes, you should have at least 30 minutes of brisk walking every day combined with weight training if possible. Now, if the patients are not able to have followed this diet and lifestyle modification for 3 weeks for a month, but still they are not being able to bring down their fasting blood sugar, which is near the diabetic range, like around 123, 124, or the PP is on the high normal range, around 180, 190, then we can consider drug therapy in those patients. In the
Correct.
drug therapy, we have metformin, which has been one of the pioneer drugs from the start. Now, in Western population, around 850 BD, 850 milligram BD has been tried, but in our Indian population, where the BMI is lesser, guidelines have come up that we should either use 250 milligram twice daily or max to max 500 milligram twice daily. Some studies have also used acarbose. Now, we counsel the patients to, with lifestyle modification and this therapy, if they can reverse their pre-diabetes. One more thing with social media is that patients often ask, doctor, is my diabetes or pre-diabetes reversible? It's only reversible if you are doing adequate physical activity and diet, and if you are able to lose 7% of the weight. Some studies have shown that it can be reversible. Apart from this diet and exercise, we can also counsel those patients who are morbidly obese and having pre-diabetes to go for anti-obesity therapies. They are not much advocated it, because all of them haven't been standardized totally, but we, in some patients, we can use orlistat if required. So
I think
we need
fabulous
to
answer.
counsel our patients that you need to reduce weight, you need to exercise regularly, you need to diet. That should be your primary concern. You shouldn't seek a drug first. First should be lifestyle modification at any
Great,
cost.
great. I think great direction you have given, Dr. Shimanti, that the number one, number two, number three is lifestyle, lifestyle, lifestyle. And you rightly said, if the numbers are close to diabetes, say somebody's PP sugar is 185, 187, fasting is 124, 125, closer to the diagnostic range, and there is no adherence to the diet, lifestyle that has been prescribed, drugs do help. And both the studies abroad, like DPP study, like DPS study of Finland, DPP of America, and IDPP study run in India, and the DIACLIP study, DIACLIP study done in India. They have all shown that the diabetes can be prevented in at least 33% cases by metformin, and it's a cheap drug.
Yes, sir.
And the other issue I wanted to ask you, that pre-diabetes is only about pre-diabetes, or pre-diabetes also includes many of the facets of pre-metabolic syndrome? I just want a very brief answer for interest of time. Do they include pre-metabolic syndrome facets also?
So the pre-diabetes patients also have been found to have increased amount of coronary artery disease and coronary risk factors. So by treating pre-diabetes, we are also reducing their chances of having cardiovascular disease and cardiovascular mortality in future. We need to treat the CV risk factors when we are treating pre-diabetes.
Absolutely correct. Therefore, I just read one of the FDA recommendations for pre-diabetes, and it said that many drugs have been used. Pioglitazone have been used. As you said, acarbose is a very strong drug. The stop NIDTM trial of Shanto is about what you rightly said. They have also used liraglutide. They have also used many other drugs. But the fulcrum, the focus has been on the metformin for two reasons. Number one, it is cheap, and it also addresses the cardiovascular aspects, which many of them others might be having, but they are not yet focused. But metformin today, as you rightly said in the beginning, is a metabolic drug, is a vascular drug.
Yes.
It is good for the heart. So that's why metformin. And I'll be good news, Dr. Shimanti, that Indian government in DCGI in India has approved the metformin to be used in the pre-diabetics to
Pre-diabetes.
prevent diabetic after the clear-cut guidelines, after 3 months of lifestyle, and when the numbers are close and lifestyle is failing, we do not want to medicalize pre-diabetes, but there is a clear indication of of metformin, preventing it in 33% cases, where the adherence to lifestyle, as you rightly said, is becomes very, very difficult. Now, last few minutes, I like to spend your directives, your dictums to our doctor friends who are in the audience. Now you know that you did mention that the DPP4 and SGLT2 is a very fabulous combination. You also added that sitagliptin is a good drug to be combined. Has sitagliptin undergone any CBOT trial? If so, what were the results, Simanti?
So in the TECOS trial, sitagliptin has shown CV benefit. It compared, whereas the rest of the gliptins hasn't shown on CV safety as compared to um, as shown by sitagliptin, because it has shown on reduction in the 3-point MACE, the CV mortality, the total mortality, and the CV death. At, so sitagliptin is one of the best gliptins when we consider in terms of CV safety, because rest of the gliptins doesn't show this CV reduction in the 3-point MACE as compared to.
Absolutely. Yeah. Bilda has not gone through this trial.
Mm,
The
mm,
linagliptin has a indirect evidence, not direct
well said.
evidence. They have a,
Mm,
compared to sulfonylureas, namely
mm,
glimepiride, it has been tried and
mm,
showed at par, non-inferior.
mm,
So I think sitagliptin stands out as the wonderful trial for the CV safety, and TECOS is one of the best trials that we have gone through. Now, I would like to ask Simanti last few questions is regarding the impact of SGLT2 combination with metformin or with DPP4 on the cardiovascular risk factors, number one. Number two, on the heart failure, whether it is HFF or HRF, whether reduced ejection fraction, rejection fraction. So, what is your comment on the impact of these two drugs? And we know today diabetes is a heart disease. We can't deny that.
yes, yes.
So, 2004 American Heart Association said that diabetes is a heart disease, not a metabolic disease. So, keeping that in mind, what are the clear-cut benefits? One, two, three, four, Simanti madam, we like to convey to our audience who are looking forward to your instructions and guidance.
So the SGLT2 inhibitors have shown their benefit in heart failure patients with or without diabetes and with preserved
It's a
ejection
great one.
fraction as well as reduced ejection fraction.
Great one, even without
So,
diabetes.
so SGLT2 inhibitor plus metformin, it not only decreases the blood glucose, but it provides cardio benefit by causing weight loss, by reducing the blood pressure, by reducing the uric acid levels. All these have shown that these might be the cause of the cardio benefit of the SGLT2 inhibitors. And as we know, the SGLT2 inhibitors have also shown in the CVOT trials reduction in the 3-point significant reduction in the 3-point MACE, the CV mortality as well as the all cause mortality. So the SGLT2 trials are one of the path changers in diabetes management, and by combining the SGLT2 with CETA, which is one more CV safe drug, we can provide benefit to our patient. We can reduce the glucotoxicity, we can reduce the lipotoxicity with the help of the SGLT2. These drugs are gluco effective, and they can bring down the sugar fast and reasonably well, so that the patient's blood sugar rapid control might delay their complications in future with the help of metabolic memory. So as we know, our Indian population is different from the Western population. Instead of going stepwise as stated by the international guidelines, if we attack fast and attack from all directions, like you said, this combination targets 6 arms of the ominous octet. We can save our patients from maybe hospital admissions, maybe CV complications, and thus provide them a good control in a shorter time. And this should be a blessing for our Indian diabetic
I think
patients.
great answer. I think I cannot repeat the answer. It is a fabulous direction. I'll just tell you a story before I end. There are two American presidents, Dr. Shimanti, and my dear audience. One American president died of tuberculosis in 1941 because the anti-TB drugs were not there. But another American president died of hypertension when antihypertensive drugs were available, and they were debating between Pickering and Platt. You remember, Shimanti, whether hypertension should be treated or not to be treated. Today, to my mind, this is a very personal opinion. I don't want to make a generalized statement, but my dear friends, I'm telling it from my experience, from my passion, not to use SGLT2 inhibitor, not to use DP4 inhibitor is acceptable. It is not acceptable because they have become affordable and they are the unique drugs, as you rightly said. They are nutritional offloaders. They take down the weight. They are, and also, I'll Simanti, I will also like you to last 1 minute left. You take half a minute of that to describe regarding the kidney benefits, the DAPA kidney trial, or anyone you can take and tell us the kidney benefits of this molecule, which our doctors will carry home the knowledge about.
So this SGLT2 inhibitors have shown that they can reduce albuminuria as well as progression to end-stage renal disease. And now we can use the SGLT2 inhibitors to EGFR as low as 25 ml per minute per meter square. So initially, what we were apprehensive in a diabetic CKD population, whether to one part of which whom has huge CV risk factors, whether to use them. Now, this group provides benefit in this diabetic CKD population also because they help in delaying the diabetic kidney disease progression and they also reduce albuminuria. So, this drug is also a path changer when we consider the SGLT2 in diabetic nephropathy. So this should always be on the top of our list is if since the cost has also come down when we are treating our diabetic patients.
Absolutely fabulous. And I think we will end with this note, as you rightly said, that diabetes today cannot be glucocentric. We have to take care, as you rightly said, of the CMR, cardio, metabolic, and renal risk. And as you've beautifully shown, I mean, Shamanti, I'm short of words to appreciate and uh, give my compliments for your beautiful, fabulous discussion this evening. I must tell you, you have beautifully said that for the cardiac benefit, for the glycemic efficacy, and without hypoglycemia, and for the renal benefits, these drugs are today absolutely on the top of the list. And you also said that Indian diabetics need early aggressive control, and they need these drugs which are safe, very safe. They call it like prescribe and forget, in the sense that they do not produce hypoglycemia, they don't produce weight gain. Both DPP4 and this weight neutral. Metformin is weight neutral, so it is a drug which is perfectly fits our population. Dear friends, we discussed about the early aggressive control. We discussed about the empowering the patient with the patient education. The patient who knows diabetes maximum lives maximum. So we have to empower the patients. And the doctors, I have a term I will like to tell you, Simanti, that there has been relentless onslaught of diabetes regarding its complications. Affects the heart, kidney, eyes, leg, liver, what not, from the hair till the nail. Every organ is affected. So there, but against relentless disease with lot of complication, there have been relentless advances. And the advances you talk today about the SGLT2 inhibitor, DP4 inhibitor, metformin combination with sulfonylurea, DPP4 and SGLT2 have been fabulous. And you use the word path breaking. I fully agree with you. They are the game changers, and they are really provided the directions what to do. And our doctors have to also move with time. They're moving with time. I'm just telling it superficially. They are moving with time. They are better informed, well equipped even than us. But I will tell them that they have to keep their knowledge highest as regarding diabetes. Because if you have to know about whole of medicine, know about diabetes. You know the entire medicine. With this note, thank you, Dr. Simanti, for the very wonderful exposition. It was a great sheer delight to be with you this evening. And I again would like to compliment the audience who have joined in large number. Because you are, we are here. Because of you, we exist, and we discuss. And we hope this discussion will help your practice and give you some food for thought. Thank you, Simanti, and thank you very much, my
Thank
dear
you, sir.
audience.
Thank you, sir. It was a pleasure, sir.